So welcome everyone. I'm happy to discuss with you the role of BTKi failures in mantle cell lymphoma. Now, this slide should just tell you that at least in the German, Austrian, Swiss guidelines, the addition of ibrutinib is standard of care in younger patients, and that we challenge autologous transplant, which had been the prior standard of care. Next slide. However, that causes trouble because if one of these patients is progressing, what are we going to do? Because we spent our most efficient treatments already in first line. And here you see in late relapse, we open the door to whatever option. And essentially, this is based on fixed duration treatment in the triangle trial. So patients relapse after completion of BTKi. On the other hand, next slide, for the early relapses, this is more a challenge because for them, it is really the point that there are few compounds registered, currently CAR T cells and pirtobrutinib, and you might also discuss venetoclax, next slide. And the whole thing becomes even more complex knowing the different registration status of different BTKis, namely ibrutinib, first generation only in Europe, in contrast to second generation only, zanubrutinib and acalabrutinib in US. So I really would like to challenge you, what are your key considerations when selecting treatment in relapsed mantle cell lymphoma in patients who fail BTKis, and what are your considerations how to plan the treatment in these patients? And I would be especially interested, maybe you raise your digital hand to know what people in other countries are thinking. For example, in US, what about you, Greg?
Yeah, that's a very difficult population to treat, as you pointed out. Those patients can have rapidly progressive disease. Typically, even in evaluation of these patients, we tend to maintain BTK when the patients progress through them because there's an accelerated disease course, usually after stopping BTK. In preparation for subsequent treatment, we tend to maintain it. And for the patients who are fit, the CAR T cells now, I think at most of the centers would be a consideration for those patients. Here, majority of patients nowadays, unless there are significant comorbidities, would be candidates for CAR T cell therapy in this setting. The other option, there's emergence of bispecific antibodies in this space as well. Switching to do the more of immunotherapy route. And venetoclax with BTK inhibitor is also used. We typically would use it more as a temporary bridging prior to CAR T cells. So we tend to add it to stabilize the disease progression, then looking towards more of a cellular therapy approaches.
Thank you very much. So Michael, you have a lot of experience with venetoclax and in your patient population. Any other approaches or focuses you would like to set?
We're a little bit unlucky in that, apart from the clinical trial context, we don't have routine access to BTK inhibitors in the front line in Australia. So our BTK inhibitor, post-BTK inhibitor relapses or patients with refractory disease, it's often in the third line. And in that context, we lean towards CAR T as the, very much as Greg has said. But the bispecifics are becoming increasingly important where we can access those in clinical trials. And one of the real issues, particularly patients who have acquired mutations in P53 or kinetically very active disease, is just how unstable these patients can be in terms of managing them and how quickly you have to move in a subset of patients. I think that's where we do lean on venetoclax occasionally to help hold things if we're moving to for example, a cellular therapy. But one of the other issues is that I think this is a population more than what we might see in DLBCL, where moving quickly to CAR T can be a challenge, and that's I think a case being made there for drugs like glofitamab, where we've seen significant activity at a very high CR rate, but not yet routine availability.
Francesc, what about these more indolent CLL kind of mantle cell lymphoma? You know, in CLL, it's frequently been treated with BTKi first line, and then only in subsequent clinical course you realize this may be a mantle cell lymphoma. Once these patients relapse, how do you manage them?
Yeah, well, we manage like a CLL, so we tend to treat the patient when they require therapy, and we use we don't have like Australia BTKi online, so we tend to use chemoimmunotherapy, maybe with Namastin or some mild regime, and if the patient relapses, then we give the BTKi, which is then approved. And in third line, then you have to consider probably the patient is acquiring mutations, and then you need to consider CAR-T for those patients.
I think that's Francesc has raised a really interesting point there, because it sounds like we have a similar circumstance. If we think a patient might move to CAR-T in the third line, we tend to get a bit anxious about bendamustine in the second line because of concerns around T-cell fitness. And so that relatively recent availability of CAR-T in the third line in Australia has changed our second line practice significantly.
So it's really, you have to think ahead of time about the sequencing of treatments, and therefore I would like to ask Gilles. Now, no one mentioned so far pirtobrutinib as some option to salvage patients after BTKi failures. Any comment on that one?
Yeah, I think it's a situation where you know, we face different kind of patients. The first ones are the patients that might not be eligible for cellular therapies because of older age or comorbidities, or because they have failed cellular therapies, and pirto is clearly a drug that is useful. We know that the median PFS of patient entering the trial for mantle cell, unfortunately, is only a couple of months. But I just saw one of my patients recently who was, you know, on pirto for 15 or 16 months until he failed, and you know, he was well tolerated and things like that. Right now, we are a little bit in a difficult situation, so I will move back for lenalidomide anti-CD20 for this patient, and Obin in this case. I think the other thing is that the patients with P53 are the patients that are treated with a triangle-like regimen in the front line and failed this approach. Hopefully only few, but there are some. And I think pirto is a good approach. I think that most of these patients, in fact, will go very quickly to cell therapy. I'm seeing one actually this morning for this indication. And this is particularly true for us with the availability of lysocell in this setting, which have broadened the spectrum of patients who are candidates for cell therapy in mantle cell. But pirto is, you know, here used as a bridge for this patient, or you know, for those who fail and have not received it before, it is a good candidate also.
Mm-hmm. So when it comes to tailoring the treatment according to the risk profile of the disease or comorbidities, what guides you into direction of, let's say, CAR T cells or bispecifics or on other approaches?
Well, just to say that bispecific right now, it's clinical trials. And I will say it remains also a challenging treatment for patients. One of my patients went recently in the ICU. Apparently, he's fine to receive the full dose today, but you know, whether it's an easy path for patient with advanced refractory bulky disease or not, and compared to a CAR T-cell approach, remains to be defined. And you know, the response rate, the CR rate is very high with bispecific in the 70-75%, but I think we have limited information regarding the duration of this response, and whether it's rather a bridge to another therapy or definitive therapy remains, in my point of view, to be determined. I think, you know, eligibility to CAR has changed with the availability of liso-cel. The question for mantle cell is that we are not convinced necessarily that this is a curative attempt, and probably we should still keep allogeneic transplantation as an option in some patients in case we are dealing with this very difficult to treat refractory patient with blastic or a form of TP53 mutation.
So you bring up a very important point. What drives your decision? Either relapse under BTKi, either early or late, let's say within the first year or only after whatever 3 years, or is it the biology of the malignant cell, Ki67 and P53? What do you think, Michael?
Well, the biology is a huge driver. I mean, I think we're now routinely having a look at the mutational profile in every case, and we're lucky in Australia that we can make that a routine part of our practice. And so that becomes something that is actually so almost a gate to the decision. Every patient we see, we check for P53 mutation now. So that's a very important element. I think the patient's youth is actually also important. We do have some patients who are younger and potentially eligible for curative approach treatments. And I think right now our leaning for those patients we have Tecartus available in Australia now, and for those patients we might go for Tecartus, but we also might be looking about you know, trying to address that issue of cure, and in that setting trying to get patients into the deepest possible remission before allogeneic stem cell transplant is a treatment goal that we're discussing with some of our younger patients. So the patient's youth is an important element if that approach is being considered. You know, how much, what are we trying to achieve? And at the moment, we're still allografting our younger patients who are fit for that, where we can get a nice, secure remission.
Mm-hmm. Well taken. Last question to you, Greg. So if you have these young fit patients relapsing under BTKi, what is your strategy? What do you tell your patients?
Yeah, so with the concerns that the CAR T-cell therapy may not necessarily provide a durable remission, I think the allogeneic transplantation is a real consideration as well. And we try to do the typing and consider it in the course of the disease as well. You know, we always try to emphasize clinical trials as well, but it is quite a difficult situation with BTK refractory patients.
Well, thank you all for your thoughtful comments. I think what became clear is that even with all the new compounds and approaches, BTKi failures still remain a challenge, and therefore it's probably for the vast majority of patients that they represent a high-risk disease, and therefore we still have to work to move forward on their outcome. Thank you so much for discussing that, and this has been brought to you by the Lymphoma Hub.